Good morning, medical physicists. Good morning, sirs. Good morning, ma, ladies and gentlemen. Always a pleasure to join you for a learning opportunity. Today, we'll be presenting Dr. Iyobosa Uwadiae will be presenting on HDR prostate brachytherapy from a physics standpoint. I'll just quickly read out a resume just before we get started. Dr. Iyobosa is a board-certified medical physicist and currently serves as the Secretary General of the Nigerian Association of Medical Physicists. She is a member of the NAMP Clinical Training and Certification Board, NCCB, and the chair of the FAMPO Professional Development Committee. FAMPO is for the whole of Africa, and a member of the IOMP Women's Committee. That's the International Organization of Medical Physics. She is the head of the Medical Physics Unit, University College Hospital, Ibadan, Nigeria, and an associate lecturer at the Departments of Radiation Biology, Radiotherapy, and Radiodiagnosis of the College of Medicine, University of Lagos, Nigeria. She is passionate about the development of medical physics in Nigeria and the region. She serves on different committees and has initiated and coordinated several projects towards the course of medical physics education, training, and professional development. She's an author, a singer, and someone who is very passionate about human capital building, teaching, training, and mentorship. Without any further ado, I'd like to, if you could join me to welcome Dr. Iyobosa Blessing Uwadiae. Thank you.
Thank you very much. You just called my full government name. Okay, so let me share my screen. Just let me know if you're seeing my screen and if you're seeing the right thing.
Yes, it's full screen and it's in presentation mode.
All right, so thank you very much, Victor, for the introduction, and thank you everyone for attending the webinar today. Just like he said, I'll be sharing our experience of HDR prostate brachytherapy, specifically at the University College Hospital, from my own point of view. Okay, I wanted to be sure that this thing can move. Okay, so for those who have been following our NAMP webinars in the last few months, our webinars have been tailored to kind of create awareness on the roles and responsibilities of medical physicists, in the various radiation medicine departments. So this webinar is still going to follow suit. So the emphasis will be on, at the end of this webinar, we would appreciate the critical role of medical physicists in the HDR prostate brachytherapy workflow. Of course, I'm going to do so by sharing our experience at the University College Hospital. At the end of this webinar, you would not know how to commission a brachytherapy machine or how to do an acceptance testing or how to do a QA or treatment planning. So just to inform you ahead that this webinar is not for that. We're just giving a general overview. We'll probably have more specific workshops, maybe during the conference or something, to address some of these issues. All right, so since this is a mixed crowd, it's always good to start with a little bit of introduction. So brachytherapy is a radiotherapy procedure where sealed sources are placed directly in the tumor or as close as possible to the tumor, unlike external beam radiotherapy, where the radiation is coming from an external source. And it is very good for the treatment of locally advanced cancer, so diseases that have not spread, especially for cervical cancer. So brachytherapy today is a very good treatment option for cervical cancer. Has good conformal dose delivery, steep dose fall-off, so the healthy tissues are greatly spared. And of course, it has other advantages. HDR specifically has the advantage of being a temporary treatment compared to, so you could have high dose rate brachytherapy or low dose rate brachytherapy, as you can see on the image on the right. Sorry, let me turn on my pointer. Okay. So the image on the right, you see a low dose rate brachytherapy procedure where seeds are implanted and left permanently in the target organ. So for HDR, it's a temporary procedure, delivers very high dose rate. So patients are treated within a very short time. This is precise, fewer fractions, and as I earlier mentioned, there's a convenience of it being an outpatient procedure. Just to give a little bit background for us to appreciate why HDR brachytherapy is good, essential, or necessary for prostate cancer. Today, I got these images from the global you can see is the highest in Nigeria and even in the region of Africa. So it has a high incidence and also a high mortality rate. UCH, just to brag a bit, UCH is the first hospital in Nigeria to actually start brachytherapy. And oh my God, so this is supposed to be 2000 and, no, this is not 2018. This is supposed to be 2008. I'll correct that. So in 2008, UCH started brachytherapy. Manufactured by Baby in 2000. Using a CM fluoroscope. So this was as far back as 2008. And then in 2019, and mouse is not moving. Okay, in 2019, the equipment was upgraded to 2 units of that same. We could now treat other cancers apart from gynecological cancers, prostate, breast, and we can do virtually all the types of cancers. So the first, speaking specifically about prostate brachytherapy now, so the first patient was treated on the 17th of July, 2020. We initially started with a fractionation regimen of 18 gray in 2 fractions, and then now we are doing 27 in 2 fractions. We started with steel needles, and of course, it wasn't economical. We had to transit to using we started with plastic needles. Those were not economical, and then we transited to using steel needles. It's an ultrasound image guided procedure. You could use CT too, but we use ultrasound. We have a stepper and stabilizer unit that can be mounted on the couch or on the floor. And as the last time I checked, so that was last week, or 2 weeks ago rather, we had treated 115 patients. And we do our prostate brachytherapy on Thursdays and Fridays, 1 patient per week for now. We attempted doing 2 patients per week, but it was very tedious. And then it was a very, very steep learning curve for us. All right, so the images are just showing us our prostate templates and the steel and plastic needles. So in our HDR program, prostate brachytherapy program, it's a multidisciplinary teamwork. We have the radiation oncologists, of course, they are the ones who prescribe the treatment, do the needle insertion, contouring, and all that. And sometimes they are assisted by urologists. Of course, we have the medical physicists. So this lecture is basically going to be emphasizing on the role that we physicists play in the HDR prostate brachytherapy procedure. Of course, nurses who are in charge of the entire operative patient care, and anesthetists who have to, of course, it's a surgical procedure, so you definitely need an anesthetist. The engineers help us to set up the prostate stabilizer and stepper units. Of course, therapy radiographers who are responsible for radiation exposure. So for in UCH, we do both monotherapy and boost treatment, but most of our patients are monotherapy. We use just a standard, based on literature recommend cancer stage T1, T2, PSA level less than 10, Gleason score less than or equal to 7, low or intermediate risk. The volume of the prostate should not be more than 60 centimeter cube. Of course, there should be no metastasis. So this is standard, but we have sometimes patients that who have larger prostate volumes, larger, higher Gleason score, or higher PSA level, but this is just the standard criteria for patients who are qualified for HDR prostate brachytherapy. I didn't put the criteria for boost, but like I said, most of our patients are on immunotherapy. We don't have external beam currently at the University College Hospital. So for patients that will require external beam radiotherapy, after they have received their brachytherapy, they are sent out to other centers that have external beam radiotherapy. And like I mentioned, we do 27 in 2 fractions, so 13 gray per fraction. And our patients are treated within, the 2 fractions are delivered within 24 hours. So as long as, I think the literature recommendation states that it shouldn't be less than 6 hours. So anything 6 hours and above. Some centers do 2 fractions, but they do it maybe weekly or bi-weekly. But for us, it's convenient for us to do it within 24 hours so that we don't have to remove the needles and do the whole setup all over again. It's very tedious and requires a lot of personnel involved. So yeah, we do 1 patient per week now. So this is just a summary of our workflow. It's a kind of abridged version, but I didn't want to focus too much on this. I wanted us to focus on what we physicists do. Sorry, I think there's noise in the background, just in case you're hearing any funny sound. So of course it starts with preparing the applicators. The nurses look at the applicators, check them, they're okay, sterilize them and all that needs to be done. The patient is prepared for the procedure, placed in a lithotomy position. Enema is done to clean the rectum. The anesthetist comes in to do a spinal anesthesia. The patient is catheterized, the bladder is drained, contrast is introduced. And then, so this is the setup of the stepper and stabilizer unit I mentioned. So after all that is done, the transrectal ultrasound probe is inserted to the stepper unit and of course inserted into the rectum, and then imaging is done, contouring is done, treatment planning is done, and of course our target is the prostate and sometimes the seminal vesicles and any other relevant tissue. And the organs at risk are the rectum and the urethra. Now we do, for our needles, we found out that the more needles we use, the better the dosimetry. So on the average, 14 needles and above, usually 16 needles. And of course, the treatment is delivered. So speaking now of physics, generally, this is just generally what we do. Because we're involved in treatment planning, commissioning of the machine, of course, at inception, QA, handling the source, treatment planning, optimization, verification. We supervise the treatment, oversee the treatment delivery, safety, compliance, research, and all that. But now I'm going to start talking about the specifics now. So our workflow, specific workflow as physicists. So we start by doing the machine QA. I'm going to show us images of that as we go, but I'm just going to list our rows. A typical day, what a typical day looks like for us during the HDR prostate brachytherapy. So we start in the morning by doing the QA, of course, like as you do for any radiotherapy machine. We check that everything is okay. If it's not okay, of course, the patient will not be sent for. So until when that is okay, then we send for the patient. We create, we file in the treatment planning system. We do that. import all the necessary data, select the right templates for the procedure, set up the target organs, name them, the organs at risk, assign those constraints for both the target and the organs at risk. And then during the imaging, so after the patient has been placed in the lithotomy position and the transurethral ultrasound has been inserted into the patient, imaging is done. So because it's an image-guided procedure, our treatment planning system is inside the room, the operating room. So we are seated just close by. Our ultrasound machine is connected to the treatment planning system. So we take correct images and ensure that they are rightly oriented. After which you do the virtual needle placements, which has to, of course, coincide with the physical needle placements. And then, of course, optimization. We keep doing that until we get the optimal dose distribution. We check, verify all those constraints that they are according to what we said. So we follow the HDR and the ABS protocol, the American Brachytherapy Society and the European Society for Therapeutic Radiotherapy. And then we keep doing all that until we get a very good plan, an approved plan. And then next thing is the treatment delivery, which we oversee. So I'm going to take them one by one. So even in the morning, while the nurses, yes, are the ones responsible for preparing the applicators and all that, but we also confirm them, visually inspect them, ensure that there's no bend or kink, even the guide tubes, that they are rightly connecting well to the applicators, the needles. So we do all that before we start, because we've had cases where we got stuck in the middle of the procedure. So we ensure that we visually inspect all the necessary equipment before we start them. And then while the ultrasound probe is in the patient and the oncologist is, going through the images, looking at the prostate, trying to find the ideal, we have a paper. So we document the needle arrangement on a paper first before moving to the virtual needle placement. So we do all that at the. And then our QA, it's, sorry, let me minimize this so that I can see well. Okay. So there are about 5 major QA tests we do. The self-test, the BEPIC system is quite, I'm not trying to promote them or advertise their product, but compared to, Varian and Electa system, I think the BEPIC system is very smart. So most things are automated and pretty straightforward. So the self-test, the system check the software integrity, the hardware functionality, the timer and all that is done during the self-test. The interlock test, we check the treatment door room is locking well, the emergency stop button is working, both the physical one and the one on the treatment control panel. We test all that. We do a warning signal test, the optical, the lights, the acoustic signal, the audio visual. We check all that. The drive test, we check the motor and sensors of the machine, the emergency retraction system, which is very important, especially in an environment where, power can be interrupted anytime. So you want to be sure that in case of an emergency, that the source will retract, quickly. And then the optical positioning. So this is this is the tool we use for optical positioning tests, just to be sure that the source is in the right position where it's supposed to be. So we do that every morning before treatment. And I mentioned earlier that the protocol we use for our protocol is based on the HDR and the ABS. So that was what I wanted to show here on this slide. I should have put that before now. But these are the protocols. So our protocol is adapted from these two protocols, and they're actually very interesting documents for anyone who's interested in knowing more about the HDR brachytherapy and the entire workflow. So another thing we do is to acquire the ultrasound images. The volume is usually defined by the transurethral ultrasound with the patient in the lithotomy position. And we take transverse images of the prostate at 5 millimeter interval. And the virtual templates, so we have a physical template that is attached to the patient and the virtual templates on the ultrasound machine. Okay, that is not here, that's not a picture. So this picture I have here is that from the treatment planning system. So you can see, you can zoom in, you see the virtual template. So the virtual template is superimposed on the 3D images that we acquire at every 5 millimeter interval, from the apex of the prostate to the base of the prostate, or the other way around, whichever one. From the base to the, and then we also include 15 millimeter margin at both ends. So at the apex end, and just to ensure that when we insert the needle, there's complete coverage of the prostate during treatment planning. And then for the virtual needle placement, so we place the needles as defined by the oncologist. So they would, I mean, there are different ways of placing needles, but for us in our center, we start by, the periphery, covering the periphery, and then walking inwards. Of course, avoiding the urethra. The urethra passes right through the prostate. So it's usually a very big problem for us, So we try to avoid the urethra when placing the needles. So that virtual needle is coincides with the paper template, or what has been decided by the oncologist. And then an initial dose calculation is done. You see the dose distribution, and then if we need to do some inverse planning optimization, we do that afterwards. And like every brachytherapy treatment planning system, our system follows the TG43 formalism for dose calculation. So after the dose calculation, virtual needle placements, we look at the dose distribution and ensure that we aim to have a high conformity index, nothing less than 0.6 for us. Our system might be different from your own system. So we aim to at least achieve anything higher than 0.6 for conformity. And we also want a high, okay, I put here a low hetero. So we want a high homogeneity index. And of course, while also ensuring that organs at risk, the rectum and urethra are also within the set tolerance limits. But most times, from the experience we've had, it's always very challenging. At the end of the day, of course, the oncologist has to decide which is a priority. And then, so this is just showing us how we verify our dose constraints. So on the left, you can see our dose volume histogram parameters showing us constraints, the constraints that we set: conformity index, dose homogeneity index, our D90, V100, D2CC, and so and so and so. And I mentioned earlier that these constraints are based on the ABS and ESTRO guidelines. So we can also see how different views, the transverse, longitudinal, and sagittal view of the prostate. The prostate is the one in green, and we can see the 100% isodose covering the prostate. And we can also see how the urethra in yellow is spared. This image shows us the needle arrangement for this particular patient plan. So this is a typical example of a good plan, but this does not happen all the time. But this is a very good plan, because you can see that we met most of our most of our constraints are shown here on this histogram parameter table. And of course, our DVH also. So we check all these things to make sure that we're good to go. We also check the physics data, the source, type of source, because our system is a Bebic system, can take both an iridium and cobalt source. So we also check, because sometimes I've had cases where, of course, we have a cobalt source, but sometimes the system is calculating using an iridium source. So we always make sure that before treatment delivery, we verify all these parameters. And after that is done, because the plan is reviewed and approved by an oncologist. And sometimes you may have to readjust, you know, even the physical needles. If, for example, our plan does not, we have tried and it doesn't meet up, you know, to our desired, we might need to change some needle positions and then replan, reimage, optimize, recontour, just to achieve our dosimetric goal. So for treatment delivery, of course, we ensure that the needles are secured well to the patient. So our template allows us to lock needles when they are inserted. And we make sure, because we've had errors where we found out that the guide tube were not properly, you know, connected. And I said the Bebic system is very smart, because it will tell you if you even use a wrong guide tube, if the length is different from what it is expecting, it would alert you, and then you go back in and change all that. But we always make sure that we verify and guide the correct guide tube and needle placement based on our plan, our treatment plan. Of course, it is part of the protocol that a medical physicist must be present during the entire treatment delivery to supervise the safe and accurate execution of the plan. A lot of things can happen, and a lot of things that have actually happened in my own experience. So, of course, we do monitor the source movement, the dwell times, check for errors on the system, and resolve the errors if anyone comes up, just to make sure that the patient and staff are safe, because nobody wants a brachytherapy accident, but they can happen if care is not taken. And of course, after the treatment has been delivered, we go in and survey the room and survey the patient before he is discharged, just to make sure that there's no source stuck in the applicator, in the needle, or in the guide tube, that it has safely returned to its house. Okay. Okay, just showing us everything we look out for during the treatment delivery. We have an audiovisual system, watching the patients. We are also observing the movement of the source, the dwell times, checking the dose rates in the room, and so on. So apart from I just want to talk a little about the QA, other QAs, apart from the daily QA that we do. This MPPG 13A, AAPM MPPG 13A reports summarizes the standard QA test, QT tests that should be done, or that we do in prostate brachytherapy. Funny enough, I cannot see my screen. It's quite tiny. Well, okay, I can see, okay, source strength measurement, of course, which we do. The recommendation here is to do it at source exchange. So we use a cobalt source. So that means once in like 6-7 years before we do that. But we do that regularly, maybe twice in a year, or for teaching purposes. So we do it more frequently than what is recommended. Of course, those who use iridium will be doing it 4 times in a year. Then, of course, the source positioning test, which we do daily. Oh my God, I cannot see. The source retraction with backup battery, of course, we do that daily. Timer accuracy is also done. Linearity is done at acceptance testing, timer linearity. Okay, I can't see, but I'm sure you can see, but just showing us all the tests that we do in brachytherapy. So I'm just going to move to the next slide so I don't strain my eyes. I'm sorry about that. Okay, so the source strain measurement, reference air camera rate measurements, we do that regularly for teaching purposes and just for, yeah, just for doing sake, because sometimes NNRA can ask, for those. So we do it regularly. And in UCH, we are fortunate, we have two well-type chambers. We have one from PTW and standard imaging. And we also have the cylindrical phantom that you can use with a pharma type ionization chamber. So we have three types of three different detectors that we use for our reference air camera measurements. And we have actually done a study that compared both the three of them, and they are very, very comparable. So whichever one is available for use. Then another very important QA test is the ultrasound for the ultrasound system. TG128 also summarizes the tests. There are about 8 tests and they are done annually. So it's very easy, no stress, once in a year. But about 4 or 5 of them require a very specialized phantom. About 4 of them, the CRS phantom, ultrasound phantom, which we do not have currently at the hospital, but moving on. So we do all the other tests, the area measurement accuracy test, volume measurement accuracy test, contouring test, and all that. And so we have a prostate phantom, this small one that you can see on the screen. We use for our area and volume measurement accuracy test, as you can see on these images being displayed here. For the needle placement accuracy test, we do not have the CRS phantom, but we can use a bucket of water, as you can see on the screen, which is what we do. So we do all these tests, like it's just once in a year, or for teaching purposes, we can do that as needed. So yeah, in summary, yeah, because I said at the beginning, we're just giving an overview of our roles and responsibilities as medical physicists in the HDR brachytherapy program. So this was not a presentation to teach you how to do treatment planning or how to do QA or how to do commissioning and all that. We just give a general overview. So in summary, physicists serve as, in fact, in brachytherapy generally, not just in prostate brachytherapy, as a cornerstone of patient safety and treatment efficacy, combining advanced physics principles with clinical expertise to commission equipment, perform rigorous quality assurance tests, planning, optimizing plans, verification, and overseeing the entire radiation delivery. Before I say thank you, I wanted to use the opportunity to hail the UCH physics team. So once upon a time, UCH had 11 physicists. Yes. At a certain time, let's say 2020, we had 11, or 2021, I think, we had 11 physicists, the best physics team in the country, in terms of intellectual capacity, charisma, and all that. And I'm not even being biased because I work in UCH. I'm just being factual. But unfortunately, many of them are no longer in UCH, but all but one are no longer in UCH. But I wanted to use the opportunity to appreciate them, and I'll tell us why in a second. So, of course, Dr. AJ, who is no longer here with us, thank God for his life. Dr. Yekunle, Mr. Agility, of course, this is myself here, Dr. Akinlade, Ms. Ayodele, Mr. Adedokun, Mr. Madu himself, Ms. Adedokun, and this is Miss Esther, Mr. Onowola, Mr. Makumaha. So, like I said, once upon a time, I want to appreciate every single one of them. They've been a wonderful part of my medical physics journey at UCH. And of course, I want to also especially appreciate these IT undergraduate and medical physics master's students who were with me in the last 2 months. Yes, of course, I've worked with many IT students throughout my time in UCH, but there are too many pictures to share. But these ones, because they were with me in the last 2 months, so that's why I'm highlighting them. So I also want to, these are the future medical field. I hope they will consider a career in medical physics. So this picture was taken in 2010, the picture on the left. This was the very first time I ever saw a brachytherapy machine. This was UCH 2010. And then I took this picture on the right 2 weeks ago. So this picture was taken on the 31st of July, 2025. And of course, I just wanted to remind myself of how far I have come. And I'm saying this because my journey in UCH has come to an end. So that's why I'm saying all this plenty talk. My journey in UCH has come to an end, and I'm grateful for all my colleagues that I've worked with, and yeah, everyone, NAMP in general. So I would use that opportunity to say thank you, and my presentation has come to an end.
Thank you very much, Dr. Iyobosa. Wonderful presentation. And the brachytherapy is always an interesting topic because there are not so many of us that